Hello, I'm Marielle Gross. I'm an OBGYN and bioethicist at University of Pittsburgh. I am joined by Jean Anderson, OBGYN and bioethicist at Johns Hopkins. And today we're going to speak about some of the unique ethical challenges for implementing telemedicine in the obstetrics and gynecology setting. So of course, the background context of the massive transition during COVID-19 from our healthcare system that was primarily happening in hospital-based centers and even ambulatory care centers rapidly moving to a telemedicine setting has ostensibly changed the topography of American medicine, bringing with it long overdue benefits, but also new risks, some of which we've anticipated and some which may be unexpected. So, for example, it's unknown how this dramatic change towards doing medicine via telemedicine as opposed to in person will impact outcomes. What will be translated well, or what does translate well from the in-person visit to the telemedicine visit, and what might we be losing when we change the modality in which we interact with patients?
So in terms of potential long overdue benefits, the institution of telemedicine may improve access of care for many women. There's also a decreased burden of travel time, expense, lost wages, childcare, things that may make accessing care easier. In addition, just with the visit itself, telemedicine will probably result in fewer unindicated and more invasive examinations, such as unneeded pelvic examinations, as well as laboratory testing. For instance, the routine use of urine toxicology screens in OB visits. There's also the possibility of eliminating some of the more perfunctory visits, such as routine post-op visits for minor procedures, which are probably not really necessary. And then there is also a potential reduction in the cost of care with the opportunity for better triage of clinical problems and fewer visits.
In addition to the many benefits of telemedicine, there are definitely new risks. The first thing has to do with what I think is most widely perceived as the benefit of increasing access to care, which is sort of the flip side, where going to a telemedicine modality is going to marginalize further those who are already most marginalized amongst our patient populations. So those who don't have a smartphone access. There's also increased impact of marginalization of those who lack a safe or private home space to conduct a visit in, because it's sort of easy for us to forget that that's one of the most important things that the clinical exam room offers, is a private and safe space to conduct the encounter. Additionally, there's many folks who lack adequate Wi-Fi to conduct a high fidelity telemedicine visit, and language barriers in particular might be worse and more difficult to address across a telemedicine platform. So in trying to think through the unique challenges of translating OBGYN care, ambulatory OBGYN care into a telemedicine setting, I started to conceptualize around what I'm considering a 5 senses approach that really thinks through the different sort of sensory components of the clinical encounter, and then thinks about each of those domains with respect to that transition from a clinical in-person visit to a telemedicine visit. And I think that thinking through each of those sort of sensory components helps us really appreciate what might be lost or what we might need to do to compensate for that transition. I'll start with sight. I think the biggest first, thing that we can think about when we think about sight in terms of the clinical encounter, that the transition to telemedicine might mean an increase in the amount of face time. We are all become very familiar with the intimacy of Zoom and other video platform encounters where you're looking straight at that person or they're looking straight back at you. And I think compared to the standard clinical visit, a greater percentage of a telemedicine visit will be spent, quote unquote, face to face between the physician or the provider and the patient. The flip side of this is the loss of exclusivity of the provider in-person time. So Whereas you might have had less time face-to-face with your doctor in a standard clinical exam encounter, you have more time, you might have more time apparently face-to-face, but there's other things that might be taking away from that. So for example, with the physician in the room, they can't really be looking at you and also doing other things. That we all know that that's very different, that you could have other windows open while you're conducting a clinical encounter, giving the appearance, almost worse, because giving the appearance of FaceTime without the actual engagement and without the making that connection and closing the loop of the communication. So that's an example of a new risk, all related to how our clinical visits go from a site-based perspective.
If we think about space, there are certainly conveniences associated with telemedicine. It is certainly directly relevant in the time of COVID for social distancing. And as already mentioned, it results in decreased wasted travel time and expense. So it's a better use of clinical space that is needed for in-person visits. On the other hand, you don't have a safe space as you do in a clinic setting where the woman and her provider are there in a private room. This is especially relevant for situations where there are concerns or the presence of intimate partner violence or other situations that really require more privacy and sensitivity in being able to discuss this. There's also increased invasiveness into home life with loss of privacy regarding what is revealed. Many women, particularly women who are poor, often don't have the luxury of having a private space at home and often live in multi-generational households. So their ability to talk openly about very private scenarios or concerns is not there. In terms of the concept of sound, telemedicine may result in a better focus on and a greater percentage of the encounter that's actually devoted to patient-provider communication, with fewer distractions potentially for the provider. But again, as we talked about in terms of space, there is a loss of privacy with many women living in as mentioned, in multi-generational households. They may not be able to talk privately. They may be very aware, or the provider may not be aware of who can hear or overhear the encounter. And so it's critical that providers consider that in terms of their use of language.
Another sensory way to look at the change between clinical in-person to telemedicine encounters is the sense of touch. As we highlighted in the beginning, a big component of this is, minimizing unnecessary or bad touch experiences where women may feel violated. The attention that's been given over the past few years to pelvic exams, which were done, for example, at every annual GYN visit, whether or not they were clinically necessary, we know that they're deeply uncomfortable and do disincentivize people from visiting their gynecologist, especially those who may be most sensitive to feeling violated by a pelvic exam, as with those who have a history of sexual assault. Again, on the flip side, there are very good components of touch, which I think can be especially relevant in obstetric and gynecologic care. And so moving to a telemedicine platform means loss of therapeutic touch. So the value of physical manipulation, whether it's, a hug, a handshake, even something that's, more significantly related to physical manipulation, such as the work that doulas do on labor and delivery, when that goes to a telemedicine platform, say because of reduced visitorship in hospital settings, what are we losing when we give up the fact that we can't physically touch each other and that we can't provide the comforts of touch and support that really aren't substituted by even our words? And then I think also relevant to the lack of being able to touch somebody is that, we can't, just like we're not doing extra unnecessary things, we're also not doing things that may be really important screening tests, like checking blood pressure and lab work that one might not get done if they weren't in the building already for the, for their clinical exam. There's a whole other separate category of ultrasound and fetal testing, which rely on physical touch of our instruments and the patient's body in order to gain that information that we are, at least in part giving up by this transition. This is sort of in a way, the best one I kind of leave for last, which is smell. But as much as it sounds funny, I do think we should take it seriously. So in a way, I think, thinking about smell as the sense, I think is really the most intimate aspect of care in many ways. This is especially true in a gynecologic setting where, people may feel especially, self-conscious or made vulnerable by, concerns about how they smell. In the sense of moving to a telemedicine visit, we lose that. And so people may feel less vulnerable or less self-conscious, less worried about something like that, and therefore better able to communicate about whether their symptoms or other pertinent aspects of the encounter that they could focus on instead of being worried about, do I smell bad? It sounds like kind of funny, but I think it's a non-trivial point. On the other hand, there is this loss of this really important clinically relevant set of sensory data. On its nose, so to speak, is something that's famously called the whiff test, where as gynecologists, we can diagnose treatable conditions that somebody may never complain to us about the symptoms of, but which we can diagnose just from the smell alone, and then provide treatment for something that may be really bothering somebody. Seeing the other side of the slide, that would go totally undiagnosed if we don't have that sort of passive information. I think also relevant to the smell issue is the opportunity that clinicians have to normalize how women smell and to demonstrate, I think, that to me meant professionalism. So we have this lack of an opportunity to really be professionals and to treat somebody with dignity and respect, whether or not they smell bad. So that to me was a big loss. And I think, the metaphorical whiff test is also something that we lose. That something about being in a room with a person gives you this sixth sense of the idea of something that just didn't smell right. Like that patient who, let's just send her to labor and delivery. There's something off here, even though it's not coming up in the numbers, even though she's not meeting any of our objective criteria to increase our level of concern, but that there's just this additional sense that we might be missing by not being in the room with somebody, and that kind of clinical gut reaction that we sacrifice or maybe partially sacrificing in telemedicine.
So I think to sort of pull things together, some questions that should be considered. What are the practical steps that clinicians can do to maximize the benefits and minimize the risks of telemedicine for OBGYN? How should we think about testing such as ultrasound and fetal testing, and in regards to their evidence basis in this setting? What happens when COVID goes away? What transformation of care will persist post-COVID? I think most of us who are clinicians feel that telemedicine is here to stay, and that we need to perhaps think about new paradigms in terms of clinical care that, again, maximize the benefits but minimize the risks of this technology. In terms of sort of closing the loop on these 5 senses and potential solutions, for sight, again, it's important in terms of potential solutions to think about new workflows, optimizing visit times. Less total time may be appropriate to really make sure that the provider and the patient can focus on the situation at hand. There can also be, as you know, technical solutions such as virtual exam room space. In terms of the issue of space, we talked about the loss of potentially safe space. And potential solution is really to prioritize screening, to use, we may be able to use text to supplement video encounters. It may be important to have codes that patients can use that they can communicate more privately, or if there are concerns about IPV or intimate partner violence.
And I especially like the idea of developing those codes when a patient schedules a visit, for example, you provide them with those codes. If you're in a room where you're not comfortable speaking or answering a question, you could say this, and the doctor will know that you're not comfortable answering that question in that room. And I think the same thing goes to this idea of space of, at least preparing patients for visits by saying, think ahead of time what you can do to be in a private space for that visit that you have coming up. Instead of just getting to the visit and they're in their living room and being like, what do? We could prepare our patients to do what they can to work with us on finding safe alternative spaces so that they can have their private visit.
We talked about sound and the loss of privacy. And just as Marielle was talking about the issue of space and scheduling visits, the same thing is important for patients to be able to think ahead and for providers to help them think ahead about the need for both quiet space where they won't be interrupted, but also private space so that they can talk about intimate and very sensitive issues. In terms of touch, in terms of potential solutions, counseling is going to be even more important. And really, I think that telemedicine offers the opportunity to think of new paradigms for care, where the telemedicine visit can be devoted to very careful and thoughtful history taking, and then the appropriate tests, including blood work and imaging, can be ordered, and then really figuring out what is needed in terms of exam and identifying at the time of telemedicine those patients who need in-person assessment.
I think that leveraging technology here and thinking creatively about ways that we can gain those benefits, like blood pressure is an example we gave before. You can't check someone's blood pressure unless you have their arm in a cuff in your office, but truly people have home-based blood pressure cuffs, and even providing them for temporary use in settings such as pregnancy, where you may really need to check on somebody's blood pressure as a very important screening tool. Well, bringing them into the office isn't the only way to solve that problem. I think if we think creatively, this forces us to really challenge a lot of our assumptions about what is required even to provide the same level of care.
And probably this technology is also going to help other types of screening tests, can help enable those in the home setting. There are already FDA-approved home HIV tests. Those things may be accelerated because of this, and that may provide some additional ways to employ telemedicine and to reduce unnecessary visits for certain women. And then finally is the issue of smell. You lose that sensory data both physically and metaphorically, and it's important to really hone the way we as providers ask questions. We always aim to ask non-judgmental questions in a screening situation, but that's probably even of greater importance in a setting where you're providing care remotely. And then keeping that sixth sense, which is maybe a little bit more difficult virtually, but trying to maintain a recognition that there may be vibes from the patient that indicate that there's something that's just not right, something that doesn't smell right, and that it's important to have a way to follow up with in those situations in person.
Mm-hmm. That about wraps up our 5 senses approach to exploring the challenges and potential solutions to transitioning OBGYN care, ambulatory care from a primarily clinic-based to primarily telemedicine-based modality. And of course, there's a lot more to explore here. So we welcome further conversations on this, and thank you for your time and attention.